Tuberculosis remains a major public health challenge in India, despite advancements in diagnosis and treatment. On the occasion of World TB Day, Voice of Healthcare is organizing a virtual campaign, TB Mukt Abhiyan. This is an awareness initiative aimed at eliminating TB by strengthening policy, advancing innovations in diagnostics and therapeutics, and mobilizing community action. This campaign emphasizes early detection, digital health solutions, public private partnerships, and social support for TB patients. By integrating AI driven tools and grassroots level engagement, India aims to achieve its goal of TB elimination ahead of global 2030 target, ensuring equitable healthcare and improving public awareness through a multi-sectorial approach. Our panelists for today's discussion are Dr. Umang, Consultant Infectious Disease, Hinduja Hospital, Mumbai. Welcome, Dr. Umang.
Thank you. Thank you so much, Dr. Khurana, for the kind invite. Excited to be here.
Dr. Divya Joshi, Associate Consultant, Infectious Diseases, Fortis Hospital, Bengaluru. Welcome, Dr. Divya.
Thank you. Thank you for the invitation, ma'am.
Dr. Girish Gaur, Associate Director, Rivaara Lab. Welcome, Dr. Girish.
Thank you, Dr. Manisha. It's good. Again, exciting to be back here with you again.
Dr. Neha Rastogi, Panda, Senior Consultant, Infectious Diseases, Fortis Hospital, Gurgaon. Dr. Neha would be joining us. So I'll start with Dr. Umang. Sir, what are the latest policy updates under National TB Elimination Program?
So I think we have a new document from their side in November 2024, wherein I think the key initiatives that they have taken this time is, as far as the treatment for drug-resistant TB is concerned, they have introduced the BPAL-M regimen, which was shown in clinical trials to be quite effective. And the major advantage of this regimen is that it's just a 6-month regimen rather than the earlier 18 to 20-month regimen. So that will have significant bearings on cost. Moreover, since the number of drugs have reduced, so the associated drug toxicities, at least from the patient aspect, would come to, at least it's expected to be reduced as well. So I think that's the biggest, that's the major thing that has come up in the NTEP. Apart from that, as far as TB diagnostics are concerned, I think they have now introduced expert XDR. So that's a new diagnostic tool that has come in. And it's recommended that whenever a sample is being sent for investigation, apart from the usual expert G4 or the TrueNAT that we do, you do an expert XDR and LPA directly with that, So I think that's a very welcome change, because with that, you will get an idea about INH monoresistance. You get an idea about MDR or a pre-XDR TB at the outset. And the third thing was the 100-day program, I think, which came to an end today. We are still awaiting the results of that. But that was basically a focused community engagement and focused participation on part of the government in certain geographic areas where the reported incidence of TB is not that great. So I think these were the 3 major changes that have come in TB 2024.
So that is addressing the resistance, diagnosis, and community engagement, right, sir? Dr. Divya, how can hospitals and healthcare providers enhance their role in supporting NTEP initiatives?
So there are a couple of things. Yeah. Am I audible? Yeah.
Yes.
So when we're talking about government and hospital corporation, we're looking at government hospitals as well as the private sector hospitals. So based on that Nikshay program that we are having, so a unique ID is actually created, and we from the private sectors also report all of these cases which goes to the government. So when that happens, there are also certain incentives which the government gives in terms of monetary benefits, in terms of money, in terms of other details. And a lot of times what happens is these drugs, sometimes when they are expensive, it is actually provided free of cost. So the collaboration which happens between the private sectors as well as the government sectors together, because we all know that TB, we have sort of the global TB capital, and the way we looking at TB, so we have seeing a lot of incidents and a lot of cases. So in that particular situation, when we have a lot of these cases, it's important to have a document, or it is important to share the list of patients so that there is a uniform area which gets recorded, and we can have a document, and then we get to know how many people are there. And then as we know, especially in cases of pulmonary TB, we do have to give prophylaxis, latent TB prophylaxis with people nearby that. So we need to have a cohort of patients that we need to know that these are the ones which are there, and that can only happen if we are providing that information to the center. So I think that is actively being taken up in all the centers, I believe, and I think that is the way forward right now. So, and we are also, there is an active screening also which is taken up from the government centers, and I think we do interact on daily basis with the government authorities who come to the hospital asking, okay, is this the actual numbers, or have we missed it out, or in those sense. So I think that this is something, this collaboration is something which is going to be very important in the near future, and I think this is where we'll actually know the numbers which we are seeing in cases of TB.
Rightly said. I think notification is what is required, and we can get to know the high risk areas. We can have the latent TB addressed by notification. Dr. Girish, what new diagnostic tools are being used for faster and more accurate TB detection?
So as of now, so we are working a lot on newer types of tools. Recent advances have happened for TB diagnostics and others also. But TB diagnostics, because as Dr. Divya rightly pointed out, we are world capital in TB disease. Almost 25% of the cases are detected in India. So other than the world, moreover we need these faster and accurate tools. So there are some recent advances that have happened, like Dr. Umang has already mentioned. There we have Gene Expert, but recently we got a new cartridge for Gene Expert, which is XDR cartridge, which actually gives information about INH and other fluorokinase and other drugs also. With that, we are entering an age of NGS where there are certain companies which are giving information about almost 18 drugs which are being used in TB treatment. With that, for areas which are like where we cannot go, we cannot have a full-fledged molecular facility. We are also looking at LAMP techniques for diagnosis of the disease, so that these infrastructure for molecular diagnostics actually need almost like 50 to 60 lakhs of investment. And in cases where we cannot have, we at least need tools which can detect and diagnose the disease in possible ancillary cases, because there is always a challenge of the conventional techniques when we are using conventional techniques. For conventional techniques like microscopy, you need to have at least 5,000 bacilli per ml of the sample. In cases the load is low, you either tend to report it as not detected, and then the patient goes off. But we need these techniques in remote areas also, where LAMP as a technique can be used very beautifully. With that, there are some biomarker-based techniques also, like TB LAMP, which is becoming very important for cases of HIV TB. Urine-based assays, you can detect TB in urine perfectly, because in these patients, no, it is first of all possibly scary cases, and because of the immune issues, it is very difficult to diagnose TB in these cases. Then there is a use of AI also in chest X-rays. Uh, I think Medanta has used it beautifully. I think the name is Quick AI, where AI is being used to actually analyze all the X-rays and report correctly. If something misses the human eye, at least the AI is pointing it out. So I think these innovations, wherever it is occurring, it is actually intended to speed up the diagnostic processes. But I think we also need to uh, enhance on the accuracy and sensitivity of these assays. So that's why I think we can tackle the disease effectively if we implement these innovations correctly.
Rightly said, Dr. Girish, and I believe that genomics, NGS tests are coming up, and they have wider coverage, and of course AI is making impact. So, Dr. Umang, how effective are molecular tests like CBNAT or TrueNAT in improving early diagnosis?
I think they're extremely effective. Traditionally, we used to have Midget as the gold standard, which probably still is, but that takes around 6 to 8 weeks to come in, wherein you get a diagnosis of TB and what drugs you can actually give to the patient. The testing of that will further take 2 to 3 weeks more after that 6 weeks. With Gene Expert coming in, or the TrueNat rather coming in, that time duration has now reduced to 2 hours. So you produce a sputum sample, and within 2 hours, you know whether this patient has RIF sensitive TB or a RIF resistant TB. And now, with the introduction of Expert XDR, as Dr. Girish mentioned, with that, you also get to know which are the other drugs that will work in, so whether it's isoniazid, quinolones, ethionamide, or aminoglycosides. So I think within a couple of hours, if you have the provision to understand the basic drug susceptibility, that is a huge way forward, anyways. So undoubtedly very effective. Uh, so as far as Dr. Gaur was talking about the newer techniques as well, so even though India has adopted Expert XDR, WHO has actually adopted the targeted NGS, bit of which what Dr. Gaur was saying. Unfortunately, in an Indian setting, we don't have that targeted NGS very prevalent. Only in high-level tertiary centers would that be available. But I think this is the next way forward for India, wherein you get information on drug sensitivity of 11 drugs at the outset. So I think that will be a huge boost forward. But I think we are moving in the right direction quite well right now.
Right. And Dr. Girish, what steps are being taken to improve access to diagnostic facilities? Although you have mentioned that point of care testing, that helps. What else is being done?
I think we need to adopt a comprehensive approach if we want to actually improve the access of diagnostic facilities in rural areas or underserved areas or what we call remote areas. I think mobile health clinics is one of the major initiatives that was, I think I can give you an example of mobile health clinics, which was used very beautifully by Medanta in TB Mukt Bharat under the. So they have almost done, I think, 1 million testing. They have a mobile unit, a van which is equipped with a portable X-ray, and they have, I think, Gene Expert also, and they have the facility to do microscopy there itself. So they have done almost 1 million testing, and they have, I think, contributed beautifully in this area. Then I think community health worker, ASHA workers, and all these community health workers, they need to be engaged properly. I think training is an important aspect here. They need to perform basic TB screening, so training is an important aspect. We need to educate communities also about what all things to look at, whether it's symptoms or whether testing facilities that are available, so that they can actually provide information to the patient to get them self-tested, first of all. Then I think telemedicine is one of the underrated areas which we have not been able to look at in case of TB. But I think we should be utilizing telemedicine in a big way. Remote consultations, no doubt. Now that we have access to mobile data everywhere, I think remote consultations is can become easy tool. Uh, Top specialists can be consulted in case of tricky situations. Um, Even this can be used to guide people in remote areas on how to diagnose and manage TBs. Uh, Even the patients can get access to good consultations to telemedicine. With that, I think decentralized testing is also important because I think most of these high-end testing tools are available at selected places only. So if we decentralize testing, I know it involves a lot of capital if we go for molecular testing, but then we have POCTs like gene experts. I think we have almost more than 3 lakh machines across India of gene expert now. But again, we have almost like 6 lakh villages. Sorry, not 3 lakh machines, but 30,000 machines. But we have 6 lakh villages which need to be given access to all these diagnostics. So I think decentralization is important, and then I think government needs to fund these machines more. With that, I think public-private partnership also can play an important role there because somehow, if you say most of these innovative technologies do come in private sector first and public sectors then follows it. I still remember the days when we used to provide PCR for TB diagnostics, and people were not even willing to get PCRs done. But due to the advantage of PCR, it should have been popularized way back. But now, with the advent of maybe gene experts, because gene experts could give rifampicin resistance answers also simultaneously, so that became popular. Uh, I think this is it. Together, these initiatives, I think, if we implement it correctly, they can reduce the burden of TB in the society.
Right. So decentralization of testing facility and training of ASHA workers. These are some important points which we have to look into. Dr. Divya, what role do AI and digital technology play in TB screening and case detection?
Correct. I think majority of my answers have been given by Dr. Umang and Dr. Girish, but then just again talking about digital part of it and artificial intelligence part of it. When we're talking about artificial intelligence part of it, we need, so it is basically any kind of a program where the computer as well as the artificial intelligence is doing the job for us. So we feed in data and then which gives increased sensitivity as well as sometimes specificity, which increases in trying to diagnose a particular thing. As Dr. Girish pointed out regarding Mantha has been using this AI part in which they've fed different radiological images into that and trying to figure out if this particular looks like this. But having said that, this is not just based on the radiological aspect. So we need actually a kind of radiological positivity. We do see every culture. So it's not just based on probably there's a radiological suspicion, then we end up sending gene expert or expert in TBC,
Uh,
the NAT test. Things where we are looking at cultures that we send for every cultures.
your
And
voice is breaking, Dr. Divya. Yeah, can you repeat? Your voice was breaking, Dr. Divya.
sorry, I'll just repeat the statement. So what I thought is when you're talking about TB, it's actually a composite diagnosis. So we do diagnose based on radiology along with the genetic testing, along with the culture, along with the histopathology. Sometimes it's a composite mixture of all of these diagnoses. We end up diagnosing TB. Not everything in place will not have each diagnostic tool available at every point of time. So the second part, when we're talking about AI and digital technology, in helping us probably diagnose, making it easier, making us know that this sensitivity part is better and we can try diagnosing it better. So that is where AI comes into play. And I think it's still a long way where we can, solely rely on something based on artificial intelligence, but baby steps at a time. The second part, when we're talking about digital involvement in terms of screening and treatment, I find consultations in remote areas is something which needs to be increased in terms of digital technology when it takes over, because that is where a lot of people will not have
I think we have lost her connection. I think Dr. Neha, you have joined.
Hi
Yeah,
everyone.
welcome.
Hi.
Hi, welcome, Dr. Neha. So I'll ask you that how India is progressing towards the goal of TB elimination by 2025.
Right, right. So first of all, sorry for joining a little late. So we have actually, to be very honest, when we are targeting the 2025, we are already in that zone that we are talking about elimination. So itself, it means that India has progressed a lot to come up to the point that we are talking about the elimination. We have a 100-day campaign running very, very nicely by the help of Honorable our Prime Minister, our DDG, our CTD division. In terms, when we say in the terms of the progression, the first thing we need to understand that the India has made a very far progress in active case finding, which is one of the major challenges, and which is the first step, which is a beginning step. In order to eliminate TB, we need to know how much TB are being there in the country. So we have increased the active case finding for almost double, like 20% to 2023. From now, 42 to 43% of the TB finding has been reported. Second, India has made a lot of progress in terms of the drug supply. So initially we have, of course, the one counterpart, I would say, the access is still a little questionable. The access is still a problem. There is a shortage and paucity of drugs. But having said that, a lot of collaborators have come. I have recently attended the TB Innovation Summit where I've seen the drone-based delivery system has also been started happening in our Indian settings. So it means we have come far further. Shorter access regimes. Nowadays, we have started resorting to a smaller duration of TB drug therapies, and that is only being possible that we have a good availability of the therapy regime drugs. Fourth, a very important progress I would say we have done in terms of the diagnostics. As I said, the key factor is the diagnosis and the active case finding. So more and more handheld X-rays in the periphery, more and more database sharing is there. Better lab facilities are there nowadays. The field-based small bio TrueNAT testings are available. Gene experts are now there in every hospital. Second line TB DST testings are also available. So definitely in terms of the picking them from the community to diagnose, to treat it, and then the tracking and the TB prevention. In all these aspects, India has made a huge progress in the coming year. Yep.
Rightly said. And Dr. Umang, what are newer treatment regimes, like the shorter regime, as we have heard, improving TB cure rates?
So I think over the past 5 years, the drug discovery trials or the Raja, I wouldn't say drug discovery, I think the treatment regimens that have been tried and the papers that have been published have been very exciting. So I think the first way forward is the BPAL-M regimen, which reduces. So as Neha was saying that we are now in a position to actually reduce the treatment duration from 20 months to 6 months. That's I think is a big way forward. And it's not just limited to drug resistant TB, even for drug sensitive TB. Now there are regimens wherein in a patient with pulmonary TB, you can reduce the treatment duration from 6 months to 2 months. So there have been very good strides in that particular aspect. And if you actually look at the treatment efficacy of all these regimens, they are quite similar to the ones that we had earlier, even with the longer regimens, but with the added positive aspect of reduced toxicity and reduced duration. And when implemented on a programmatic scale, the kind of cost benefits that the government would have would be humongous, frankly. So I think this is where we are moving forward quite well. There are certain trials now which are actually looking into a 4 month regimen for drug resistant TB. Of course, we still don't have data pertaining to that, but I'm sure that we would have those papers in the next 5 years. So, yes, I think going forward, I think this is what we are looking at.
And Dr. Divya, what is your take on strategies that can help prevent and manage drug resistance TB?
So now we're looking at more and more, and drug resistance is not just MDR TB. It has now come as pre-XDR TB. The definitions have itself changed of resistance TB in the past. In the past 1 or 2 decades, we've seen maximum papers coming in terms of treatment, and has already been highlighted: shorter duration of regimen, BPAL-M regimens, etc. So that has been fairly covered. Now, what we can do in combating this and helping it out is two things. One thing that the government is doing is the availability of these drugs, which is BPAL, bedaquiline, and when we're looking at, we have delaminid over here. So all of these things, they don't give it freely available. So it is only available in the government sectors and only in those private institutions who have partnership. And I know that Hinduja, Manipal, other institutes, they do have this partnership available there where patients can be screened by the government people, the medicines can be provided by them, and as well as the treatment can be afforded in both these areas. So one thing is, when these drugs have not been available throughout for abuse, that also helps in reducing the resistance chances. That is one thing. The second thing is the partnership which is there, and the memorandum which is signed of understanding between both the parties, where a care can be given from both the fronts in terms of the private as well as the government sector. I think that also helps in understanding and making this better. And lastly, I feel diagnosis, increasing the diagnosis, and expert XDR study, or expert XDR test which has come up. So which is a reflex test, as pointed out by Dr. Umang also, after expert MTB test that we do. And if we see there is a rifampicin resistance, at the same time, we get to know other 4 to 5 drug resistance that we can give at the same time. So we already know with isoniazid resistance is there, or we have fluoroquinolone resistance is there, etc. So that also helps in having an effective treatment options that we have and we don't have to wait for the cultures anymore. So the part where and everything basically usually always starts with proper the proper understanding of the disease and telling the patients and awareness. That is the first step. And after that, all of these things in terms of diagnosis comes into play, and expert XDR tests that we have, and the part where the drugs are actually regulated by the government, and availability of the drugs in this particular setup. So all of these things will help us in better management of the resistance TB. Thank you.
Right. So managing depends on drug sensitivity, and if that is available, especially the rifampicin, which is available at the time of diagnosis, and also isoniazid being integrated into drug sensitivity, I think that's a very good step. And availability of drugs, I agree that that should be made available and accessible. So, Dr. Girish, how is patient adherence to TB treatment being improved through digital intervention like 99 dots, Nikshapitra?
I think this is a perfect question for India, at least, because we have improved a lot on our digital footprints, the way we have implemented it. And why not use it for the benefit of one of the biggest disease that we are facing right now, TB? I think dots, 99 dots, and its previous program, I have worked in that previous program also, dots. There was always a challenge where to track the patient, how to track the patient, how to check the adherence, whether the patient is taking the doses or not. So if we can introduce the digital thing in that, it actually works beautifully. So I think the 99 dots, it's a digital tool, no doubt about, and it's a tool where patients actually receive real-time monitoring of how they have adhered to the regimen through their mobile systems. And there is a trick there. The patients have to call a toll-free number post taking the medication to confirm their adherence. Secondly, if they have not taken it, there is a SMS reminder which is automatically triggered to tell them that you have not taken these drugs, and it's actually a kind of motivation or a push to the patient and make them accountable. Plus, I think this also helps us in collecting the data and monitoring the patients on regular basis. With that, I think Nikshay was a portal which was started by Government of India to actually take care of all the patients, because we do a notification there and the patients are then followed up, whether the patients have taken proper drugs or not, whether they have been lost to follow up or not. If and they are targeted based on the phone numbers, the unique phone numbers. So if they have been lost to follow up, and if they then again go somewhere and get diagnosed, then at least the treating person knows that he or she has taken that kind of a regimen till that time. So Nikshamitra actually has improved a lot of things, because ultimately this Mitra word is a friend word, where every patient can be connected to a Mitra or a friend uh, who actually provides a kind of motivation or encouragement, and the person also follows up and supports the treatment. With that, I think if there is somebody who can provide personalized motivation, personalized support, I think that helps a lot. Uh, because sometimes there are people which are in the lower state of the society who cannot use digital tools like 99 dots. So they need some kind of a manual motivation, manual support. So in that case, this Niksha Mitra has performed beautifully. I think by leveraging the technology that we have this positive thing of technology in India. At least the data is so cheap. These interventions, if actually taken properly, we can overcome the barriers of adherence, and the TB disease or TB treatment can be made more effective. So I think, yes, overall, we are working beautifully on these two digital fronts.
Rightly said that digital tools are effective and they help us in monitoring the adherence and, of course, attaching mitra, that is a very beautiful word, to a patient would definitely motivate him or her to take the medicine. Right. Dr. Neha, how can integrated care model that combine infectious diseases management with TB treatment improve patient outcomes?
So definitely. So first thing we need to understand that whenever we are talking about in terms of the infectious disease, where the tuberculosis itself is a part of it, so we need to have a integration. The name itself means that we have to have an integrated model. Of course, it has to be decentralized, but we need to understand that one infection can begets the other, be it in terms of communicable also or a non-communicable also. I'll give you a simple example. When we talk about tuberculosis itself, being having a diabetes and on the same side in the communicable and HIV per se. So, I mean, the infectious and non infectious, if I talk about, both go hand in hand and both can influence each other in terms of their patient outcome overall, patient adherence to the regime, which we were just talking about. When you have a higher pills for both the diseases, of course, there has to be a drug drug interaction. So, the integration I feel should be at the three different level. One is a very important is a clinical integration, which we are talking about, simultaneous or a concurrent testing. For example, when we say that these days, even as a part of our policy, when we have a tuberculosis, when the NICSHE guideline, when the NTP guidelines mandates that we should have a mandatory HIV testing or an HbA1c too. Second is important, like I said, the imaging wise, in terms of clinical integration. So we were talking about the AI. When we talk about AI and when we see an X-ray, suppose, so it has to be in totality with the lung health, not specifically related to the tuberculosis. Because when we are seeing a nodule or some kind of infiltrate, it can be tuberculosis, it can be a pneumonia, or it can be even a lung cancer. So the first perspective from an integration is to have a clinical integration, because patient is coming as a whole. It is not coming a TB plus HIV plus diabetes plus hypertension. So that integration needs to be there. Second, very important is the organizational integration, which I think we all are talking in terms of the different sectors or the different areas. Like, for example, even talking in this meeting, all boarded amongst with the different kind of a setups, it itself is an example that how the different organizations can come up into the picture. And that is very important in terms of a decentralized model for a care in especially a disease like tuberculosis. Right from the counseling, right from the advocacy, from the patient reaching a PHC or any level of care, and then coming to a right care provider, this kind of integration model does exist. And the third very important integration is at the community level, because until and unless we don't engage from that area, we are not going to harbor. And again, I would go back to my previous statement: active case finding, intensive case finding, this all should come from the community integration. So integrated model, when we say in terms of care, it starts right from the education, awareness, suspicion, diagnosis and treatment.
Right. And addressing the non-communicable like diabetes and communicable like HIV, infectious disease, along with TB is again very important. And community, of course, this is what we have to look into. And my next question then goes to Dr. Umang, that how is does the community, help us in TB awareness and early detection?
I'm sorry, I didn't get your question. Apologies.
How does involving various communities help us in TB awareness and early detection? Dr. Umang, yes.
So, by and large, I think that is a very, very important step, because until and unless the community is aware that this is a problem, no one is really going to come forward. For instance, there is a big social stigma associated with you having TB or with HIV, and especially if you have both, then the stigma increases and the patients themselves are reluctant to seek medical care. So I think it's extremely important to involve the community in the management of this. And I think Dr. Gaur has already spoken a lot about Niksha Mitra. And it's, I think, a wonderful initiative by the government to use this particular term, wherein any individual, any society, or any corporate setup, or any private setup can actually be a friend to the government in initiating these programs. And by and large, the impact also is now quite visible. So apart from the usual social support and the counseling support that the mitras provide, they have been empowered to provide even nutritional support, which is extremely important. I think there was a lovely study which was published in Lancet, which showed that in an Indian setting, most around 46% of the patients are nutritionally deprived. And if you just increase the nutrition apart from the TB drugs, that itself was an independent risk factor of low mortality. So that is a very, very important step. And towards this aspect, I think we have a government program in place wherein every patient who's been registered with NextEdge would actually get a nutritional support of 1,000 rupees per day. So I think that is a phenomenal program that the government has come up with. Apart from that, with regards to community participation, as soon as you start involving other individuals as a part of this particular initiative, they themselves would spread the message across, and you will have more people, which will help in reducing the social stigma as well. That's
Very important point covered. I think nutrition is one thing which we need to address, and giving good nutrition can definitely help us decrease the mortality. Dr. Divya, what are the key steps to reducing the stigma around TB?
Right. So Dr. Umang has already talked about a lot of stigma, and it is not just sometimes TB alone, it is HIV. First, understanding that, telling them that what is communicable and what is not communicable into the setting. Am I audible? I think I was.
Yes, yes,
Yeah,
yes.
yeah. So we'll have to try and understand what parts, as we know that TB can affect each and every organ of our body, as rightly pointed out, from skin to eye to lungs to bone, etc. Anything that you know, and understanding which can spread from one person to another is also equally important. So first, making the patient or the attenders along with them, as well as the community, understand that when we're talking about communicability of TB, we're looking at pulmonary TB being communicable. There are extra pulmonary angles to TB, which involves a lymph node TB, pericardial TB, pleural TB. It can be gastrointestinal TB, genitourinary TB, CNS TB, bone TB, etc., etc., etc. All of these things will not spread from one person to another. So the part where everybody needs to understand that not every patient has to be treated like an untouchable. In fact, no patient has to be treated like an untouchable is something which needs to be told. The second most important part is making them understand that if the patient is an intensive phase regimen, and when we are acquiring sputum samples, repeated cultures, smears, etc., which is coming out to be negative, does not, and understanding that they will not transmit the disease beyond this point. So all those parts to make them understand. So we're looking at a 15-day period of 2 months, maybe 15 days period when they've taken an intensive therapy. After 2 months, we're looking at the sputum clearance again. All of those things making them understand in terms of pulmonary TB. Thirdly, also making them understand that if they adhere to the program, then there is a quicker chance of the recovery. And post that, after the quicker chance of recovery, the communicability in terms of the pulmonary TB also comes down if they are adherent to their medications, as well as drug resistant part comes down. So firstly and most importantly, making them understand, and communication is actually the key in trying to make them understand about all of these factors and things. This is the most important thing, and making them understand that not every TB is communicable, because they come to the OPD setting, and this is one of the most important questions. And I think everybody is of the same opinion. Is it going to happen to my kid? Is it going to transfer to my grandchildren? Everybody asks these important questions. So understanding the disease, most important is understanding the disease is important, what area is affected, and understanding which patients also do need latent TB prophylaxis to be given, and screening actively will, all of these things will help in reducing the stigma. And as always, knowledge and communication is the key. So that is what I would end this thing with. Thank you.
It's a good message that every TB, cannot be transmitted to your family members. Go to a doctor, understand what TB is, which part of your body is affected, and then only make any decision, right? So, Dr. Girish, how is the private healthcare sector contributing to TB detection and treatment?
I think it is an important question, at least from the Indian point of view, because private sector, healthcare sector has played a significant role in detection and management of tuberculosis. I'll just give you two data. One is about the initial care seeking behavior, where I think 41% of the people with TB first seek care for private facilities, because a substantial proportion of individual normally don't go to public sector hospital in the first go itself. I think then there is a diagnostic capabilities also. We know that every government hospital or a public sector hospital has facilities for TB diagnostics, but then the data suggests that almost like 43% of the surveyed private facilities, uh, they say that the first diagnostics is done by the private sector uh, diagnostic facilities only. Despite all these things, I think similarly in radiography also, the private sector is playing a bigger role rather than the government sector. Because normally uh, a normal person doesn't want to go to public because there is a I think a dilemma whether I'll be treated in the first go itself or will I have to uh, maybe come next day also, then for diagnostics next day also. So I think the private sectors in that case are playing a very big role as far as the diagnostics and the initial care behavior is concerned. Uh, there's a perceived behavior also when it comes to should I say private sector, uh, because people think there is a shorter waiting time. There is a dedicated attention towards this. Quicker diagnostic results are available. Uh, so that is why it encourages people to go for private sector business. We can argue a lot of things about private and government, but I think this is what is the reality of the system. Uh, but as far as I think private and government sectors are concerned or public sectors are concerned, there is the recognized need of collaboration, effective collaboration is needed because ultimately what we are looking as TB as a big disease where both private and public sector have to play a very synchronized role where uh, the patient has to be treated despite the fact he has been diagnosed or the first primary care has been given by a private sector. Then if the patient doesn't have that capability of getting drugs in the private sector, he can always be referred to the public sector uh, hospitals. I think in conclusion, I think I feel private care sector actually contributes a lot significantly towards the initial diagnosis, detection, plus as I said, initial care. But I think we also need to popularize that all these diagnostic facilities are available, uh, maybe at free of cost. Because ultimately, if you go for CBNAT, which is available at say around 2000, for, I'm just talking about the first rifampicin MTB, and another I think $3,000 for XDR cartridge. So I think we need to make people aware that these diagnostic facilities are available free of cost in public sector hospitals. Then I think we can increase. I think the way public sector hospitals are perceived. They can be perceived in a very better way. But ultimately, I think we feel that strengthening collaboration between these sectors actually can enhance overall TB management on both on the TB diagnosis as well as TB treatment.
Right. So collaboration is what is needed, right? He said. Similarly, Dr. Neha, how can collaboration with the pharmaceutical and biotechnology companies accelerate TB research and innovation? Dr. Neha, I think there's some network issue. Okay, so Dr. Umang, I'll take up your question that what initiatives are in place to improve reporting and notification of TB cases from private clinics?
I
Dr.
think I
Umang?
just lost you in between. Khurana. Yeah,
Yes.
yeah, yeah.
So what? Yes. So what initiatives are in place to improve reporting and notification of TB cases from private clinics?
So, by and large, I think Dr. Gaur has discussed quite a lot on this topic. But at least from a private hospital perspective, at least in our setting, how we go about it is any patient for whom a TB test is requested, for instance, whether it's a gene expert or a TB midget or whatever, there is a system in place wherein all these patients are actually notified to the government, and our hospital has actually been given the go ahead to create a Nixia ID as well. So for any patient wherein a gene expert is requested, a Nixia ID is created, and it is so we have two or three people who are only working on communicating with the government that this particular case has been notified. So that itself increases. So ours is one of the largest biggest TB centers, one of the biggest TB centers in Asia right now. So that is how the notification rates increase quite significantly. And apart from that, even physicians, private physicians, for instance, even if I'm starting the patient on TB treatment empirically, so as physicians, we do notify the government as well. So I think from a private sector, this is one thing that we can do. And that is how we move forward. So I think this really helps in increasing the notification rate as well to the government.
Right. Dr. Neha, can you hear me now?
Yeah. I can hear. Yeah.
Okay. So, can you tell us that how collaboration between pharmaceuticals and biotechnologies company accelerate TB research and innovation?
Sorry, your last sentence got broken. Yeah. Can you
Yeah.
repeat?
Yes. So, how can collaboration with pharmaceuticals and biotechnology companies accelerate TB research and innovation?
Yes, right. So definitely, there is a lot of scope and lot of work has already been done. As I mentioned, that I was there to witness the 2 day long TB Innovation Summit, which just happened in 18th and 19th. There were more than 350 plus innovations just to answer that question. So when we say innovation does not always meant to be, because my understanding, and I'm sure everybody was, is that innovation is something new and out of the box. What we realized in tuberculosis, that providing equity and access even to the existing technology itself is an innovation. So we have learned about a lot of times those kind of innovations as well. So talking about in terms of the therapeutic innovations, we have seen a lot. So delaminid or bedaquiline for that example. So delaminid came as a collaboration only with Otsuka Pharmaceuticals. They started with a collaboration with the program, and then it started with the WHO, and then came it to the NTEP to start with the delaminate procurement. That was the first example which we talk about. In terms of the diagnostic, CIFID, FIND, PATH, they have all been the great leaders and the innovators in terms of when we talk about the diagnostic interventions. PAN TB, that is a project to accelerate the newer diagnostics and neurotherapeutics of TB. Panda TB has come up with the global funding collaboration when we talk about in terms of the research and innovation. I got a chance to actually expertise one AI based healthcare system in tuberculosis session, where I realized that the AI has taken a lot and digital has taken a lot in terms of inspire the TB care as well. Right from the good algorithms to diagnose tuberculosis, to target the primary healthcare providers to give the TB in a better way, to target the testing in the better way, that itself has come up with the long terms of the diagnostic collaborations, as I mentioned, with the group called CIFID. Mall Bio is a very good collaborators of ours, which has given us a true NAT in the form of a team field testing, which has really revolutionized the way of TB testing in even the fields and the peripheries. Therapeutic collaboration, I would say, is still going hand in hand. There are the BPAM regimen is also a live example of how we had a collaborators, which has given us a compassionate ground access initially for bedaquiline and delaminate, and eventually they become the new arsenals in our TB therapy, and now every regime involves around that. So when I say innovation, access, access and equity, as I mentioned, and awareness about those innovation and how to incorporate them into the existing model is really important. And in tuberculosis, I can see the very well example in terms of both diagnostic and therapeutic going hand in hand.
Very well explained. So systems are improving, and of course, these biotechnology companies and pharmaceutical companies are helping us to improve our system and to have a better patient care. Right. So, Dr. Divya, how can hospitals ensure better access to TB care for marginalized population?
Marginalized populations, when we are talking about people in certain areas and sectors where availability of healthcare resources are a limitation, but the government is doing a lot in terms of getting diagnostic facilities in place, like every hospital having a true NAT which is available, so that whenever there is a suspicion, there is actually a form which is there in which they would have done an HIV testing for those patients, sputum testing for those patients. So we all know, and everybody realizes the importance of TB being a healthcare problem, and one of the biggest healthcare problem, and that is why we are accelerating towards it. Even in marginalized populations, we're looking at genetic based testings which is being available. So that is one of the things that we have achieved in this particular TB situation right now. The second part is those areas also do not miss on sending cultures, which are extremely important and not just genetic based aspects of these things. So these are two very important things in marginalized populations where they come. The other part is how it has helped and how they can help is there are areas where there is a app based technologies which can reach, or tele digitalization or tele communication which can happen, in which a doctor is being available and they can have and communicate their issues and difficulties, and they can manage side effects, etc. Because managing TB is not just about diagnosis and treatment in a duration of about 6 months, and now looking at shorter regimens. And when we're looking at regimens which are involving CNS TBs, etc., it is not shorter than an year's course of TB treatment. So when we're looking at all of these things, we also face a lot of side effects. And one of the biggest problem that we are facing right now is currently stopping of the treatment because of the side effects. So that needs to be spoken, that needs to be addressed when we are discussing with the patients. And until and unless they have a constant source of communication which can be maintained in these marginalized population, that is not going to happen. So that source of communication can either come from the government people who have these workers, or who are giving pamphlets and or organizing the treatment which is being available to these patients, etc., as well as incentivizing, as rightly pointed by Dr. Umang, that getting 1,000 rupees in terms of nutritional benefits. All of those things are just trying to make sure that the patient takes these medicines properly in time, does not leave it, and they are also counseled on the need of a lot of side effects. We're not just looking at the side effects in terms of ethambutol related eye toxicities, or in terms of liver toxicities when we're looking at 3 or more active regimens, drugs in terms of rifampicin or pyrazinamide or even isoniazid. So when we're looking at all of these things together in these marginalized population, first is diagnosis, where we have expert CBNATs, TrueNATs, which are available. The second important part is discussing with them or making a healthcare facility or workers available from the government with whom they can discuss these side effect profiles, what to take, and incentivization in terms of delivering proper nutrition. I think that should be the way ahead, and that is what we are trying to achieve through our government setups, as well as a collaboration with the private part. So
Right. Associating, some ASHA worker or NGOs can come up and then incentivizing. These are the ways by which we can address TB. Dr. Girish, what is your take on future plans and commitments that can help us achieve TB-free India?
I we have a good plan, future plan, where India can actually uh, achieve TB Mukt Bharat. That is what we are looking at. So as far as the Indian government is concerned, I think it has laid out an ambitious plan to achieve that. Uh, but I don't know whether to 2025. I think we are sitting in 2025, so whether we will be able to achieve that in 2025. But yes, we are doing good work. We are working towards it. I think even WHO has appreciated that part recently in 2024. That the report that we have published from the History of Health. Recently conducted, I think Dr. Umang mentioned 100-day TB elimination. I think Dr. Neha also mentioned that. We have just completed that in 2024. Results are still not available, but I think it will give us some insights on how to improve these programs. With this NTP, when we started NTP in 2017, I think there was a big roadmap which was laid down, and we are working towards it. But yeah, we had some hiccups during the COVID times, but I think we'll try and overcome those hiccups shortly. With that, I think we are working towards a lot of improvements in diagnostic techniques, and there are certain regimens which have been approved for shorter regimens that have been approved for treatment, which I think Dr. Umang and Dr. Divya have already mentioned. So enhanced diagnostic facilities will help us to detect and diagnose the patient early. With these regimens, I think adherence to the regimen would improve. Uh, with that, Dr. Umang has already mentioned about the initiative that government has taken to uh, incentivize patients on the front of meals or for the food. I think this is known as Nikshay Poshan Yojana, where a certain amount is given to the patients per month to take care of that food thing. This financial aid actually is important in case of patients who are very poor, because they don't want to then adhere to the treatment. With that, I think there are a lot of engagement programs on the community side also, which is being done by the TB elimination program. I think one is the Pradhan Mantri TB Mukt Bharat Abhiyan, which is actually working good in the community engagement program. And then there are certain international collaborations also, which the government of India is looking at. I think Dr. Neha has mentioned some part of that. And the 2025 TB elimination thing was actually based on the WHO 2030, the sustainable goal that was declared by WHO. We wanted to complete it 5 years before that. I think, in conclusion, the Indian government has future plans, and I think their commitments towards achieving TB-free India actually is a comprehensive program. I think we are on track to achieve that. That yes, some dates would be tweaked because of this COVID thing that happened, and we will be able to achieve it.
On that note, I also believe that India's fight against TB requires collaborative action, cutting edge innovation, and by strengthening community engagement, leveraging advanced diagnostics, and ensuring equitable access to care, TB elimination is within reach. Together, we can build a TB free India, improving public health and setting a global example in disease eradication. Thank you so much for joining us today.
Thank you so much.
Thank you so much, Dr. Khurana, for the kind
Thank
invite.
you. Thank you.